Okay, so today we have Dr. Lidia Shapira from Stanford University. So I'll have her introduce herself and then maybe give an overview of your background and all of that.
Well, thank you for the opportunity. I'm Lidia Shapira. I'm a medical oncologist, a professor of medicine at Stanford, and I direct the cancer survivorship program here. Hold on. I'm going to disconnect my AirPods because they're not working and they're giving me an echo.
No problem.
Can you hear me now?
Yes.
Okay. Um, they were probably not properly charged, but I could just.
Oh, now I can't hear you. I can't hear you.
Check the
Oh,
microphone.
there. Now I can hear you.
Can you hear me now?
Yes.
Okay, so I'm a medical oncologist and have been for a very long time with a practice focused in breast cancer. I'm a professor of medicine at Stanford, and I'm also the director of Stanford's Cancer Survivorship Program. So I oversee the services that we have for cancer survivors and have a program, a transdisciplinary program doing research to sort of expand what we know about cancer survivors and how we can think we're always thinking about interventions that could help improve quality of life or improve outcomes for this very important population. I'm delighted to be here with you today.
Thank you. So what kind of drew you into becoming more interested into looking into these holistic issues with regards to women with breast cancer?
I think just being with them and being
Mm.
their doctor. So
Yeah.
these are the things that we've always talked about.
Hmm.
I think that, pretty familiar with the lived experience and the reporting of concerns and issues that arise for women after being treated for breast cancer. So certainly that's been what has sort of fueled my interest in accompanying them, in educating other professionals to better take care of them, to building a referral base, and to contributing to the science and knowledge to sort of advance what we can actually do for them.
Hmm.
Um, Being treated for breast cancer often impacts relationships, life, body image, one's own sense of the future, one's relationship to one's body. And I think there's an incredible role for rehabilitation and for occupational therapists
Yeah.
in that support team.
Hmm. How well right now do you think that the psychosocial needs of women with breast cancer are being addressed in the medical community?
So I think there's been a growing recognition that this is
Mhm.
important, and
Mhm.
I'm certainly um, enthusiastic about what I've seen, and I think there is a I've seen a sort of a growth
Mhm.
of supportive services. I think people are talking about it more.
Yeah.
There are more people who are training in perhaps health professions and designing supportive interventions or
Mm.
complementary interventions to address these needs. So overall, I would say that we're making progress.
Mhm.
And my hope and dream would be that the woman or the person who is diagnosed feels more accompanied, feels that they can express their concerns and have some of these supportive interventions introduced earlier. So not
Mhm.
wait until there is a problem, but do more prevention, accompanying, and support.
Mhm. As far as those areas that you've seen growth in, what would you say those are? And then what would you say are like those unmet needs that you think really need growth?
For example, the understanding that there's going to be a change in body image as a result often of surgeries and local
Mm.
therapies.
Yeah.
I think the field of lymphedema,
Mhm.
treatment
Mhm.
has improved some, although I'd still think that we could use better treatments. Since since when I started, we would do basically compression, and we still seem to be doing compression. It'd be
Hmm.
great if we can actually figure out more about the pathophysiology and design additional treatments. But the good news is that by de-escalating some of the therapies like the surgeries and so on, we now have fewer women who experience that very
Hmm.
uncomfortable and serious long-term and late effect of treatment. So I think that I've seen, you know, um, more open conversations about sexual health and intimacy
Hmm.
think is important because I think
Yeah.
that's also an important area. I've seen more research and even guidelines for counseling about family building after cancer and fertility preservation and pregnancy after cancer. So
Hmm.
I think that both in the psychological domain of providing supportive care and the physical domain of providing um, referrals to treat things like lymphedema or sexual dysfunction. I think that's all progress uh,
Hmm.
and all good things. And I think the areas where I think we need to do more probably are in the mental health. I think that addressing some of the anxieties that happen, the fears that some women carry, and the feeling that, sometimes they feel lost, sort of at the end of active cancer treatment. I think those are areas that we could do much better in.
Hmm. I know like lymphedema is an area that's really big in occupational therapy, and sexual health is another area that's kind of taking off as another niche area to get into. So there's two really cool and blossoming areas.
Yes, and all of the ways in which occupational therapy can also help with dealing with some of the symptoms of early menopause that many young breast cancer survivors experience through
Mhm.
pelvic floor rehab, through
Yeah.
many other rehabilitation kind of
Mhm. Yeah.
techniques.
Yeah. Pelvic floor is really big in OT and also physical therapy too.
Yeah.
Um, so from your research, how has the stress of a cancer diagnosis, how does that play into like family dynamics? Because you were talking about mental health and all of that.
So, I mean, there's not even my research, but other people's research, for instance, has shown that maternal depression, for instance, during cancer treatment can affect children, right? So
Mhm.
these are some of the things that we fear. So I think that for especially if we're talking about women during parenting years, I think their
Mhm.
mental health will affect the mental health perhaps of their children. So it's very important um, to try to really think about supporting our
Mhm.
patients and helping with communication in families.
Mhm.
I think that parent guidance interventions, for instance, can be enormously helpful. And I have colleagues who've done a lot of work in that area. So I would say that the diagnosis and treatment cause an important interruption in life. And
Mhm.
times that means that relationships shift, careers may be interrupted, kids and families, may sort of need to adjust to different people taking on roles that perhaps they were used to having their moms do, but their
Mhm.
moms temporarily need some help. So all sorts of things can happen, I think, as a result of, sort of a woman during, active parenting years uh,
Mhm.
needing to take time off for cancer treatment. And if she is anxious or she becomes depressed or she doesn't feel good about herself or her body or some of her physical abilities are diminished, it's easy to see how that can interfere with and affect multiple members of families. I've seen many patients who are incredibly resilient, who are
Mhm.
able to overcome it. I've seen some families grow closer
Yeah.
and I've seen supportive partners adopt roles during cancer treatment and families, really use this as ways of really showing their love for one another and so on. But I do think that it is a major stress, and many people need professional help. It's not just that, they're everybody's gonna, we have this wonderful fantasy that people are just gonna come up and help, but there are many people who actually need professional help to deal with many of these issues.
Yeah, I was just thinking about as you were talking, role loss and how could you advise therapists? Like I'm in the inpatient setting right now, and I see so many people dealing with role loss, whether it's like parent or like role loss, and they're sitting in the hospital bed all day, just like staring at the TV screen or just kind of staring into space and kind of just like dealing with the mental health repercussions of just not having their life that they used to have? And how could you advise therapists dealing with patients who are going through that? How could you advise them?
Yeah, well, I'm not a therapist, so
Yeah.
there may be people who are much better at finding the precise language. But from your comment, I would say that perhaps staring at a wall is just not helpful.
Yeah. Yeah.
So I think that we're talking about things about important sort of recommendations at different levels. At one level, it would be to see if there are any accommodations that could be made, at work to allow people who are interested in continuing to work
Mm-hmm.
to continue to participate, albeit with a perhaps reduced schedule or, different sort of different responsibilities. Because what I've seen is that many of my patients who enjoy their work
Hmm.
actually find it helpful to continue working
Yeah.
through their cancer experience. And they tell me that otherwise they would actually think that they would sort of freak out if they have too much time on their hands or
Mm.
don't have the kind of distraction and focus that many of us who are during our working careers have and enjoy, including relationships, with other
Yeah.
adults based on
Hmm.
on projects or common work. So that's one thing. The other is that to sort of engage maybe in activities that provide peace, calm, and pleasure and satisfaction. So maybe reading or watching films or
Yeah.
having conversations. I think what I hear from many of the my cancer patients is that feeling connected to others is incredibly helpful. So
Hmm.
I think that what I would recommend a therapist is first of all to listen to what it is that makes that individual tick and what they love to do. Try to
Hmm.
figure out if they can shore up their supports and have them, reach out maybe to friends or others to feel connected, have conversations, and not to spend too much time sort of ruminating or staring at a wall. Um,
Hmm.
so I think that's what I would say, sort of trying to keep people feeling that they're still engaged, helping them feel that they can manage whatever it is that they have to do, helping them feel more
Yeah.
capable, and helping them sort of work towards, some rehabilitation goal. If it's
Hmm.
possible, get out of bed and
Yeah.
get on an exercise bike in a room or, walk laps around a hospital unit, go
Yes,
sit in
exactly.
a garden, go out, and do things. So try to maintain both mental, social, and physical uh,
Hmm. The full scope.
function.
Yeah.
Yeah,
Hmm.
yeah.
Yeah. I think another challenge that I've really read is both weight gain and then also the physical changes that come with like having a mastectomy or um uh what's the word that I'm looking for?
Lumpectomy.
Yes, yes. Um
So,
all the
yeah,
physical changes that come with that, how that changes your body image, and then also how that can be affected by socioeconomic status too. So, what are your thoughts on that?
yeah. Well, some of the studies that our group has done, others have done, have unfortunately shown that some of the women who are most impacted by these are women who may have lower resources to
Mhm.
start with, which is hard to hear, but it's
Mhm.
probably a
Yeah.
reality. And no clinician will be terribly surprised.
Yeah.
So I would say that, even in my practice right now, I refer a lot to a colleague who specializes in post-lumpectomy, post-mastectomy, sort of physical rehab, or,
Hmm.
so I think an evaluation, I think helping people, for instance, to learn techniques of self-massage if they have some edema in the chest wall, giving people exercises to restore, a full range of motion in the right upper quadrant, teaching people how to self-monitor for signs of lymphedema and to call or get treatment. I think
Hmm.
there's a huge amount of things that can be done with OT, eval, and laying hands on a person.
Hmm.
So while I'm a great fan of giving people educational resources and videos, I think an in-person evaluation to help somebody um, you know, become better able to manage their body after they've had the surgeries and after they've had treatment is very important. Um, I think many of the things that you say um, are are crucial and in terms of adjusting, adapting, accepting, and I think that's sort of where the secret sauce is, because
Yeah.
different people bring to this, different things. And I think that one of the things that you mention is that after, especially after certain surgeries, there may be also some level of grief, that
Yeah. Yeah.
people are sort of still mourning their lost body part.
Hmm.
And some people are much more, you've seen this already, I'm sure, more resilient than others in sort of accepting and adapting and moving forward. And others seem to need a little bit more help. But I think that's the work that we all need to do as a team,
Hmm.
I mean, help our patients understand that they've invested a lot in getting treatment for cancer, that goal now has been achieved and they should feel
Hmm.
good about that. And now the question is to figure out what we can do to support them and help them so they can move forward.
Hmm.
Some things will just require, some acceptance. That's what many cancer survivors describe as new normal. There may
Yeah.
be new things that need to be accepted that are now part of,
Hmm.
the way things are.
Yeah, and that comes with everything. You touched a little bit on the OT eval, which is something that I wanted to ask. Like when we go through our list of questions, a lot of times we don't typically ask about body image or sexual health. And I think it's because people aren't sure if that's something that you should bring up to a patient or if that's something that they should bring up to you. And I don't know what your thoughts or what you've read on that. So I wanted to ask what
I
you
think
think.
that's a great question. I think that it depends a little bit on where you meet them. If you meet them in a pelvic floor clinic, I think asking about sexual
Yeah,
function has to be part of what you
yeah,
do, right?
yeah.
Because, but if you meet them, maybe about they're coming in with you because they were referred because they have some cording or they have, limitation at the shoulder, maybe they will be like a little taken aback if you ask them about intimacy or sexual health. So my advice would be to tailor the symptom assessment to the role
Mm-hmm.
and the referral reason, but to give everybody an opportunity to tell their cancer story. And even if it takes a few minutes off the time to say how has a sort of a general open-ended question like how has your cancer diagnosis affected the way you feel about your body? That's a
Mm-hmm.
perfectly fine question to ask. And you'll be cued by the answer. Somebody will say, "Oh, I'm here because I'm tense here." Or somebody may actually say, don't I don't like the way I look. I haven't been able to
Mm-hmm.
look at myself. I haven't been able to let my partner look at me or whatever. And then you might say something like, have you shared this with anybody? How do you think I can help you with this? And even if it's not something that you can have a treatment for, you can at least say, I recommend that you speak about this with your oncologist or your primary care doctor. There are people who may be able to help you with that as well. So that's the way I would counsel anybody that, when you enter into a therapeutic relationship with a cancer survivor, specifically to address a symptom to say, how has this affected you? Are there concerns that you want to share with me? Is it okay if I
Yeah.
give you some advice?
Yeah. Yeah. It's just patient to patient and not so setting to setting and how you phrase a question. Yeah. What about fear of cancer returning? How do you as an oncologist address that? And then how can that translate into how you would advise allied health professions to address that issue?
So we know that it's common. We know that among breast cancer survivors, it's very common, and the statistics and studies vary a lot because it depends a little bit on what is measured or what assessment is done. But,
Mm-hmm.
even from the studies that our group has done, I would say that there's sort of a spectrum. So
Mm-hmm.
in some cases, that fear um, improves with time. So it
Mm-hmm.
subsides with time. But
Yeah.
there is certainly a minority of patients who experience that very acutely and it doesn't resolve.
Mm-hmm.
So I think those are people that are important for us to reach out to as well and
Yeah.
offer mental health um, interventions. There are some very good evidence-based mental health interventions to deal with it. We can all contribute to um, helping patients and resolving this a little bit by how we talk to them. Like
Mm-hmm.
if I tell a person who's already very anxious to begin with to
Mm-hmm.
watch out for any little symptom, I
Mm-hmm.
may unintentionally stoke that fear.
Yeah. Yeah.
And I think that's what we want to try to avoid. So, what we're really dealing with is anxiety about managing uncertainty,
Mm-hmm.
not knowing, wanting a good outcome, but being afraid and feeling
Mm-hmm.
very vulnerable that the worst can happen, which means the cancer coming back or the cancer killing them or suffering from cancer. And I think that those are really important fears. So, I think just as we talked about before, opening the conversation, by saying, do you worry about the cancer coming back and seeing what you get? Or saying some of my patients worry that the cancer could come back. Is that something that you've experienced? And if they
Mm-hmm.
say yes, then try to figure out what the intensity and severity and frequency is, just like you would with any other symptom.
Mm-hmm.
Is that something that intrudes into your thoughts every day? Is that something that is keeping you from enjoying the present? Um,
Mm-hmm.
and then trying to figure out if it's something that you need to refer, like you can say something like, I have colleagues who actually specialize in helping cancer patients with this. You know, would it be okay if I make a referral, or, have you thought about talking to a mental health professional about that? And if it's something that somebody says, I think about it intermittently or occasionally or before my mammogram or when I come see you or when I
Mm-hmm.
have an appointment with my oncologist, then you want to maybe normalize it a little bit and say,
Yeah, that's a
we
normal.
hear we
Yeah.
hear that we hear that from so many patients, and it's hard because you've done so much to stay well, and nobody can really look ahead and guarantee what the future is like. But I think what we all want to do as healthcare professionals, whether we're OT or oncology or primary care, is help people understand that, that worrying about the future is not
Mm-hmm.
going to make the future better.
Yeah.
It's not going to guarantee that things are going to be better, and that there's some level at which you need to accept the fact that we don't know.
Mm-hmm. Yeah, there's a lot of that unknown in the future, and I could see how that would make anybody fearful, no matter if they have cancer, if they have any sort of progressive chronic illness or anything. So just assuring somebody that there is somebody that you can refer to if that's more of a intrusive kind of fear that they have in their everyday life, and normalizing it if it's something that is just before a doctor's appointment or before something that might make them more fearful.
Yeah.
Yeah. Um, so what guidance would you give to allied health professionals or somebody who's new in the field of oncology or of occupational therapy who aims to assess and address these underlying causes of psychosocial challenges like body image, sexuality, all of these kind of concerns?
Yeah, I think my advice is to learn something about them, uh,
Hmm.
to look at some of our, for instance, the National Coalition of Cancer Networks, NCCN, has survivorship guidelines and stuff, and there are some assessment tools there. So learn some questions that have been part of, that have been validated and are helpful. So
Hmm.
have those ready, and be non-judgmental and open and ask people. And
Okay.
so ask people open questions about things, as we said before, and learn some of the questions that are used in order to screen people who really need to be referred to a specialist for that.
Okay. Okay. Do you find that it's easy to incorporate standardized assessments in this area?
I think it helps. I think
Yeah.
having some standardized questions really helps, just like having scripts for certain communication tasks is
Hmm.
helpful because then things flow.
Yeah.
And so if you say, for instance, if you have a question about emotional distress ready, or a question about, anxiety ready, or a question about sexual health ready, like, are you having any problems, with intimacy or sexual health? Just something even
Yeah.
open that opens the question and whatever. And then again, I think one of the things that has often inhibited some health professionals from asking questions is feeling that if they don't know how to fix a problem, they'd rather not talk about it. And that's just not helpful for cancer survivors. I
Yeah.
think opening the conversation, helping people feel that it's safe to
Mhm.
say that they're worried is good. And then
Yeah.
say, look, I'm trained in OT, but
Yeah.
let me make a recommendation, or let me just write, is it okay with you if I write a note to your referring physician and say, you know, Jane told me today that she actually is waking up at night worrying about this,
Yeah.
something
Yeah.
like.
Yeah. Well, thank you so much. Hold on, I'm gonna stop recording for a second.